Hey everyone, Dr. Steve here. You know it as well as I do, but most students need a B or better in A&P. But did you know that students are doing that all over the US using my Anatomy and Physiology Digital Suite as a low-cost alternative to expensive textbooks? Digital Suite delivers the key concepts of A&P with short, assignable tutor videos and a bulleted narrative study guide that not only explain the concepts of A&P, they show them happening. Combined with state-of-the-art dissection and physiology lab simulations and a vast question bank for quizzes, homework assignments, and exams, Digital Suite meets students where they are and gives them the tools to master the content. It's the perfect supplement to an OER textbook or just on its own. If you're an A&P instructor, contact your McGraw-Hill representative today and ask about Anatomy and Physiology Digital Suite. If you're a student, tell your instructor about it. There's a link to Digital Suite in the show notes of this episode. Get your B or better in A&P with A&P Digital Suite.
Insurance isn't one size fits all, and shopping for it shouldn't feel like squeezing into something that just doesn't fit. That's why drivers have enjoyed Progressive's Name Your Price tool for years. With the Name Your Price tool, you tell them what you want to pay, and they show you options that fit your budget. Enough hunting for discounts, trying to calculate rates, and tinkering with coverages. Maybe you're picking out your very first policy, or maybe you're just looking for something that works better for you and your family. Either way, they make it simple to see your options. No guesswork, no surprises. Ready to see how easy and fun shopping for car insurance can be? Visit Progressive.com and give the Name Your Price tool a try. Take the stress out of shopping and find coverage that fits your life on your terms. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law.
Hey everybody, welcome back to my podcast, Anatomy and Physiology Bit by Bit. I'm your host, Dr. Steve Sullivan, coming to you from Bucks County, Pennsylvania, where I've been teaching A&P since 2002. Today's episode is about autoimmune disease. It's a general class of diseases that includes multiple sclerosis, lupus, type 1 diabetes, thyroid diseases like Graves and Hashimoto's, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, celiac disease, Crohn's disease, ulcerative colitis, and so many others. I mean, the list goes on and on and on. These diseases are caused by someone's immune system essentially going rogue and attacking their own cells instead of just attacking pathogens and foreign invaders like they're supposed to. As usual, this podcast should in no way be taken as medical advice. If you or someone you know is experiencing any of the signs or symptoms discussed in this or any episode of my podcast, please get evaluated by a medical professional as soon as possible. Since there are so many different types of autoimmune disease, for this episode we're going to focus simply on what autoimmune disease means physiologically and pathologically. We'll use other episodes down the road to get into the specifics of different types of autoimmune diseases. Typically, the kind of doctors that treat these diseases are called immunologists or rheumatologists. And today we have a very special guest. Dr. Alexis Barbut, MD, is a board-certified rheumatologist with a clinical focus on reproductive rheumatology, women's health, and autoimmune disease. She's a medical doctor in Western New York, way up near Lake Ontario. I've been following Dr. Alexis on Instagram for some time and have been really impressed with the information she shares about scientific literacy and evidence-based medicine. So I think you'll all be much better served by hearing about autoimmune disease from an actual expert in the field than just from me. We discussed what happens to the immune system to make it go rogue, what that does to our cells and tissues, what are the risk factors, how do we diagnose it, how do we treat it, and what's the outlook. I really enjoyed my conversation with Dr. Alexis, and I learned a ton about autoimmune disease. So whether you're driving, at the gym, riding the bus, going for a run, or just lounging out, I hope you enjoy learning about autoimmune disease as much as I did. So without further ado, please welcome rheumatologist Dr. Alexis Barbut. Okay, welcome to the show, Dr. Alexis. Before we get started talking about autoimmune disease, would you mind letting our listeners know who you are and what you do?
Yeah. Hi, Steve. Thank you so much for having me. I'm really happy to be here. So I am a board certified rheumatologist. So I specialize in autoimmune disease and inflammatory diseases. So these are things like lupus, rheumatoid arthritis, vasculitis, connective tissue diseases, kind of the whole umbrella. And really like the biggest part of my job, I would say, is to figure out, is the immune system causing the symptoms or is this coming from something else? Because not everything that feels inflammatory or seems inflammatory actually is. There's a lot of mimickers.
Yeah, I feel like for autoimmune, especially mimickers was a big thing, right? I
Yeah.
remember when I was in school learning about MS and Lyme disease, and they're like, we got to watch out for mimickers
Yep.
because you don't know. That's so. When we talk about autoimmune, I tell my students all the time, think of autobiography. An autobiography is written by the person who it's about. So autoimmune means self-immune.
Right.
So when we talk about immune disease, and we hear about it all the time, that term, there's all different kinds. But in
Mhm.
general, when we use the term autoimmune disease, what exactly does it mean immunologically, and how does it differ from immunodeficiency?
Yeah, that's a great question. So autoimmune disease is really when the immune system loses its ability to distinguish self from non-self. That's its main role. And it's amazing at doing this, at recognizing foreign invaders. So things like viruses, bacteria, but it's not perfect. Your own immune system can start attacking your own cells. And this is a lot of the times through something called autoantibodies. So antibodies, is like your body's little army that fights off infection, but it can get confused and go after your own tissues. And we also have things like autoreactive T cells and just general inflammatory pathways and cascades that can just become dysregulated essentially. And I take care of a lot of rare diseases, and we do a lot of like, what we call orphan diseases. But autoimmune disease in general is actually not so rare. It affects up to 10% of people. And then when we think about immunodeficiency, and that's a really good thing to kind of highlight the nuance and the difference here, it's the opposite problem. So it's where your immune system actually cannot mount an adequate defense or response when there's a pathogen. But the interesting thing is there's kind of a connection between these two things. The same systems that prevent autoimmune disease also help regulate immune defense. So I would say when there's a breakdown in regulation in general, you can see both of these things. And one kind of interesting tidbit is that we can sometimes see that an immunodeficiency can predate the onset of an autoimmune disease because they're so interlinked.
Oh, interesting. I didn't know that. You
Yeah.
mentioned a term I never heard before, orphan diseases. What is that?
So orphan diseases are considered very rare diseases.
Okay, I'm going to interject for a second here because I was really curious as to why these rare diseases are called orphan diseases. And it turns out that because they affect such a small percentage of the population, fewer than 200,000 people in the US or under 1 in 2,000 in the European Union, they've been quote unquote orphaned from research interests. Essentially, their rarity makes developing treatments unprofitable for pharmaceutical companies. Common examples of orphan diseases include cystic fibrosis, Huntington's disease, amyotrophic lateral sclerosis, or ALS, and Duchenne's muscular dystrophy. The rare ones, they're still there. There's a lot of people in this country, so even something that's 1 in a million, you can come across it.
Absolutely. Yeah. I could certainly walk into the hospital if you're working there, walk into your clinic. I mean, people are getting these things. So,
Yeah.
yeah.
So a while ago, episodes 56 through 58, I covered the immune system on a normal perspective. So that was the normal A&P of the immune system and how it works. We did first, second, third line of defense. We talked about antibodies or immunoglobulins. So the listeners should remember the concept of immunocompetence, which you can speak to that. So
Yeah.
could you sum up immunocompetence in a couple of sentences and then maybe at a broader level explain the mechanisms that would cause the immune system to lose immunocompetence and start attacking your body's own tissues?
Yeah. So immunocompetence, it's an interesting word. And, sometimes people will say, like, I have a really strong immune system. I never get sick. You hear people say that, but I don't think about immunocompetence as strong. It's more well regulated. You have a very regulated immune system. So we talked about, with the first questions, the immune system really has to do two things. It has to go after real threats, and it has to just be really good at ignoring your own body completely. And this balance is essentially what immune tolerance is. It's the balance between those two things. And I think you had talked about this because I had listened to some of those episodes as well, that there's these kind of two layers. So there's central tolerance, which happens early, and it's when, these immune cells are made. So T cells in the thymus, B cells in the bone marrow, and the body actually is asking the cells this question of, do you react to self? And if the answer is yes, those cells are getting deleted. But quality control is not perfect. So there's some that escape. And then there's peripheral tolerance, which is kind of like the ongoing background mechanism that's keeping these cells under control. And most of those are something that we call T regulatory cells or Treg cells. And then there's, other things like immune checkpoint inhibitors. We call that like something called PD-1 or CTLA-4. And so autoimmune disease essentially happens when these checkpoints fail. But I will say that, we talked about how the body's not perfect and there's allowed to be some error. The problem happens when, if you think of it like a seesaw, when, there's too many errors and we're missing too many of those cells, and now we've tipped into autoimmunity. But, autoreactive cells can exist in people who don't have autoimmune disease, which I think is an important thing. We're allowed to make some errors, essentially.
Right, right. Yeah, that's the scary part.
Yeah.
Um, so you had mentioned the people say I have a strong immune system, and it made me think back 6 years ago, or maybe 5 years ago during the pandemic, and I would see people constantly say things like, I don't need a vaccine. I have a functioning immune system. And
Yeah.
I'm like, the reason the vaccines work is because you have a functioning immune system.
Exactly.
Yeah. And like, it's just like, come on. Yeah.
Yeah, it's like if you have a quote strong immune system, then you're a perfect candidate for a vaccine because you'll mount this
Perfect. It's
response.
the other people is the reason why we all need to get the vaccine is to help
Absolutely.
protect the other people. Yeah.
Absolutely. Yep.
So, so many diseases, and I've talked about a handful so far in this podcast in my shift to clinical pathology instead of normal A&P. So many diseases can be linked to genetics. We talked a little bit about epigenetics in one of my episodes, environmental exposures, infections. We had an infectious disease specialist on a couple of weeks ago, hormones and things like that.
Yeah.
Which, if any of those, appear to play a role in the development of an autoimmune disease?
Yeah. So that is a hot topic and a really layered question. But I would say the short answer is it's all of those things and it's none of them alone. So autoimmune disease, more than, probably a lot of other diseases, is multifactorial. We know, and it's very well studied, that it's kind of like a two-hit hypothesis, that there's a genetic susceptibility in someone plus an environmental trigger, and that precipitates this loss of self-tolerance. So, genetics absolutely matter. Specifically, there's something called HLA genes, which are like human leukocyte antigen genes. And, there's a couple in particular, and we're truly identifying more and more every day. But like something called
Yeah.
HLA-B27 is something that we know can confirm more risk for ankylosing spondylitis, for example. But interestingly, like we look at twin studies and identical twins don't even get the same disease. So it's definitely not just genes. Environment is huge. Cigarette smoking is a major, major environmental risk factor, specifically for rheumatoid arthritis, but other diseases as well. And viruses. I mean, we know that patients who have a virus, specifically Epstein-Barr, there's a link to that in the development of lupus. But some viruses can precipitate autoimmune disease, and when that happens, and I think you might have touched on this in prior podcasts, that's something called molecular mimicry, where the body's fighting the virus, but then the body gets confused and goes after your own tissue.
Mhm.
Epstein-Barr virus can infect B cells and whatnot. And then you had mentioned epigenetics. And I think of epigenetics as really like the bridge between the two things. So it's how the environment's actually changing the expression of someone's genes. And the hormone piece, I love that you brought that up. I mean, we know that, 75 to 80% of autoimmune disease is female predominant. And diseases like lupus it's 9 out of 10 patients with lupus are female. So that's an astounding, female predominant disease. And a lot of this is driven by hormones. So we know that like that estrogen can amplify immune responses. And we also know that just having, two X chromosomes instead of one confers more risk because the X chromosome carries immune genes. So there's a lot of, biologic and immunologic reasons for why this tends to be more female predominant. But it's not one of those things. It's a mix of probably all of those things. And I also just kind of like to add in, like when we think about environment, I always want to make sure that patients are not blaming themselves because it's really a perfect setup, the gene plus the environmental trigger.
Right. That's interesting about the identical twins.
Yeah.
And that really is good evidence that it's not genetics alone, that something else has to kind of flip that switch a little bit.
Yeah.
I remember in my cellular pathology classes, they talked about that. I mean, we're talking 30 years ago, but they talked about how usually one in injury or insult isn't enough to really flip the genetic switch on the cell.
Right.
And cigarette smoking comes up in just about everything I talk about on this podcast because it's just the worst. It is absolute worst.
It
I
is
tell
the
my students, like from day one in my class, I say, I'm going to be on a soapbox about cigarettes the entire time you know me.
I'm right there with you. And I tell
Yeah.
people also, like, it's never too late. I mean, you can undo a lot of the damage and really prevent
Yeah.
progression of disease. Absolutely.
Yeah, for sure.
Yeah.
And you also mentioned ankylosing spondylitis, which is not only a fun thing to say, but a really interesting way that I use that specific disease to talk about to my students about anatomical terminology and how like we can take something because I think they used to call it Maurice Stumpel disease or something like that, but
Okay.
back when they used eponyms. And it's like,
Yeah.
well, what does that tell you about it? But ankylosing spondylitis tells you everything about it. It tells you it's an inflammatory disease. It tells you where it is. It tells you what's happening to the spine.
Yeah.
We have a
Yeah.
museum here in Philly called the Mutter Museum, which is a medical oddity museum. And
Okay.
there's a skeleton, I think it might only be a torso of
Okay.
someone who had ankylosing spondylitis. And I mean, everything's just one bone.
One that bamboo
Yep.
spine. It's just, yeah,
Yeah.
absolutely.
Yeah.
Absolutely. Totally fused.
Um, so what I find interesting is that autoimmune diseases, affect some organ systems selectively, like you have MS, where it really attacks specifically the myelination or myelinated central nervous system neurons, but others produce widespread systemic manifestations, like lupus. I know lupus has an arthritis component. It has a breakdown of the like a distal arteries component, right? Things like that. You get the face, the malar rash, I think, with lupus, if I'm remembering correctly.
Yep.
So why would some have such a specific target and some be more of a systemic
Yeah.
disease?
So it really depends on what the immune system is targeting. So some immune responses are directed at what we call a tissue specific antigen. So an example of that is like Hashimoto's thyroid disease, which is the autoimmune cause of hypothyroidism. And that antibody, we call it the anti-thyroperoxidase antibody, specifically goes after enzymes in the thyroid. It's a systemic disease, but it really targets the thyroid. Now, with, autoimmune diseases that I take care of as a rheumatologist, like lupus, you gave a great example. Those autoantibodies target things that are present in every cell in your body. So, DNA and nuclear proteins. And so that's the big difference. And like you said, lupus can affect the skin, the joints, kidneys, brain. I mean, no organ is spared because all organs have cells in them, which have DNA in them.
Right. And I guess when you have something that maybe specifically targets the thyroid, then you think, well, what does a thyroid do? The thyroid then targets everything,
Right.
right?
Yeah,
So the domino effect is
absolutely.
going to be really widespread,
Yes, yes.
even if those cells are targeting one thing.
Exactly, exactly.
Yeah.
Yeah. So I would say, they're all systemic and certainly like if left untreated, like thyroid, for example, you can see manifestations everywhere. I mean, even in the joints and the heart and so nothing is spared in untreated autoimmune disease.
Yeah. And you mentioned being a rheumatologist, and I did want to make this point. So when someone's a rheumatologist, that doesn't mean they just treat rheumatism or rheumatoid arthritis.
Absolutely.
Could you give a quick little thing to that to the
Yeah.
listeners?
Yeah, so I love talking about that and I try to highlight that a lot because people tend to think that as rheumatologists we just treat arthritis, but we don't actually treat all arthritis. We treat autoimmune arthritis. So, rheumatoid, which is autoimmune, as opposed to like the mechanical loss of cartilage that we see in osteo, which is age-related arthritis. We really don't treat that and other things where there's loss of self-tolerance essentially, so lupus, Sjogren's disease, dermatomyositis, vasculitis.
Psoriatic arthritis, that's another one, right? Yeah.
Yeah, and I would say like one exciting thing about this field is that truly, like, as the days pass, there's more diseases that we discover that we take ownership of
Hmm.
in school.
Interesting. When I was in school, one of the big radiology things that we used to do was OA or RA. Like
Yes.
that was that was every test had OA or RA, and we were looking, was it osteoarthritis or rheumatoid arthritis? And there were
Exactly.
like so many different things that
Yeah.
broke that apart. We actually,
Yeah.
a lot of us have stopped calling it osteoarthritis and started calling it degenerative joint disease because it's not really an inflammatory process.
Right,
Yeah.
right. Yeah, and it's interesting. I mean, there's so many names for it, and I know a lot of times people say wear and tear. I don't love saying that because patients do truly feel then like, well, guess I shouldn't use the joint. When in reality, we know putting tension on the tendons and joints is actually helpful for it. But yeah,
Hmm.
exactly. Distinguishing osteo from inflammatory or autoimmune arthritis.
Right. So,
Yeah.
what are the most important early clinical clues as a practitioner like yourself that should make a healthcare practitioner suspect an autoimmune process rather than an infection or maybe a malignancy or a degenerative disease like osteoarthritis?
Yeah. So this is the fun part. This is the part where I feel like my job is being a detective, and this is where it gets really fun. So, I mean, autoimmune disease tends to be multi-system, like we talked about. And so we'll see, if someone has something going on in their kidney, their lungs, and their joints, or, skin, brain, and peripheral nerves. Usually there's more than one organ involved. The other thing is inflammatory symptoms, like you were mentioning in school. Always that question of, is it osteoarthritis or is it rheumatoid arthritis? When I'm seeing a patient in clinic, it's always, is this inflammatory or non-inflammatory? So, prolonged morning stiffness, joint swelling, pain that wakes people up at night and is worse when they're not moving is inflammatory joint symptoms. Whereas, mechanical symptoms is, the knee pain that's bad with stairs. And just when there's a few unexplained things happening at once, like rashes, Raynaud's, where the fingers feel cold, change color, like white to blue to red, mouth ulcers, and we can see it in the blood work too. Numerous abnormalities across multiple systems, like renal dysfunction, cell counts going down. So I would say like a big clue is just when things don't neatly fit into one organ system. That's it. That's a huge sign.
This episode is brought to you by Progressive Insurance. Do you ever think about switching insurance companies to see if you could save some cash? Progressive makes it easy. Just drop in some details about yourself and see if you're eligible to save money when you bundle your home and auto policies. The process only takes minutes, and it could mean hundreds more in your pocket. Visit progressive.com after this episode to see if you could save. Progressive Casualty Insurance Company and Affiliates. Potential savings will vary. Not available in all states.
I was actually going to ask about lab findings because I'm curious. You mentioned being the detective, and probably, I'm guessing, 80 to 90% of what you're looking at is the patient history and your clinical exam and things like that. But are there typically lab findings that would help to make a definitive diagnosis or rule out
Mhm.
mimickers that you could use? I guess like something general like an ESR or something could tell you that there's an inflammatory process. For listeners, that's an erythrocyte sedimentation rate. But are there other things, like more specific things than just general inflammation? I mentioned the erythrocyte sedimentation rate, and I want to explain what that test is. Often called a SED rate, it's a blood test used to detect and monitor inflammation in the body. It measures how quickly red blood cells, or erythrocytes, settle at the bottom of a tall, thin, vertical tube over the course of 1 hour. Normally, red blood cells settle slowly. However, when there is inflammation, the liver and immune system produce special proteins, kind of like fibrinogen, that cause red blood cells to stick together in clumps called rouleaux. These clumps are more dense than individual cells, so they sink faster to the bottom of the tube. A lab technician measures the distance the cells have fallen in millimeters, and the faster they fall, the higher the ESR, which typically indicates a higher level of inflammation. It's a very general lab test for inflammation and doesn't suggest a cause to the inflammation, just its presence.
Yeah, so labs help, but only in the right context. And I would say, like everything in rheumatology, they're one piece of the puzzle. And you're absolutely right. There's kind of like an old school nature to rheumatology that I think makes it fun, where the story matters, I would say, more than anything, what the patient's telling you sitting in front of you. But, common things that we check in ESR, as you said, something called C-reactive protein, which is another marker of inflammation that our liver makes. That one we tend to look at a little bit more than the ESR, but both of those together. There's other things like something called an ANA, which stands for anti-nuclear antibody, and that is truly a screening test just designed to pick up on some of those autoantibodies that a patient can have. But I would say, like I highlighted before, you're allowed to have a couple autoreactive antibodies. And so, 20% of the population can have an ANA that's up and it doesn't mean anything. And then there's just disease specific antibodies, things we look at more for lupus or more for Sjogren's disease. We look at, patients' complement levels and their urine testing. So it kind of depends on the clinical scenario and what we're thinking.
You just heard Dr. Alexis use the term complement. In immunity, complement is a category of antimicrobial proteins which works best against fighting bacterial infections. These proteins are synthesized by the liver, which then releases them into the blood. The more than 30 different complement proteins work in conjunction with antibodies, which are the proteins that disarm specific pathogens by binding their antigens. Since the antimicrobial proteins of this system complement the effective antibodies, it's called the complement system. You can learn all about the complement system by going back and listening to episode 57, which is my episode on the second line of defense of the immune system. In that episode, I talk about the complement system and explain how it works. Okay. I know that we're trying to be general, but you mentioned a couple of times Sjogren's disease, and I am not familiar with that. Could you tell us what that is?
Yeah, so Sjogren's is an autoimmune disease that goes after salivary glands and lacrimal glands. And so patients with Sjogren's have a lot of dryness, very dry eyes, very dry mouth. But again, it's a systemic autoimmune disease, so they can have other features too, like joint pains, rashes, and there's specific markers that we can check in the blood for that. So there's something called anti-Ro and anti-La. Sounds like a
Okay.
doctor's book, but that's what they're called.
Yeah, yeah, right. It does. It does. Oh,
Yeah.
thank you. That's
Yeah.
good. I hadn't heard of that one. So I brought up X-rays, rheumatoid and osteoarthritis
Yeah.
before, but are there other imaging studies that you would do again to kind of get a definitive diagnosis or rule other things out?
Yeah.
X-ray, MRI, CT, things like that?
Yeah. So X-ray is fantastic. I mean, it's cheap and easy, and we can look at it ourselves. We look for erosions in the bone or the pattern of the joint spaces being narrowed. So X-rays are fantastic. In rheumatology, we do a lot of musculoskeletal ultrasound now, which is a newer thing, which is really cool because with that, we can actually look at the tendons and see if there's active inflammation in the joints. MRI we can do as well. MRIs, of course, are expensive. So, we try not to order that more than we need, but that can pick up inflammation in the joints as well. And then CT scans we use when we're thinking about other organ manifestations like autoimmune lung disease or vasculitis. Those are times we would get a CT scan. But, we definitely don't just scan randomly. We really try for it to be targeted depending on what they're presenting with.
When it comes to treatments, so I guess this is what people with autoimmune disease really want to know. And I'm going to date myself. I don't know if they still do this, but in the 90s, they were injecting like gold or silver with rheumatoid arthritis. Are they still doing that?
No.
Okay.
Yeah.
So was it gold or silver? I don't
It was
remember.
gold. Yeah,
It
no,
was
you're
gold. Yeah, they were injecting gold. Gold's so much more expensive now than it was in the 90s. So
I know,
maybe.
I know. So if people still have it, they should probably hold on to it.
Yeah, right. If you've still got a syringe filled with gold, so they don't. I would imagine corticosteroids are a big part of it for their immune suppression and for their anti-inflammatory properties. What are
Yeah.
the go-to treatments for autoimmune diseases, and are there new therapies on the horizon that you're excited about?
Yeah. So we use a lot of different medications. So kind of, and again, to keep it, the basics here. So we use something called immunomodulating medication. So we don't want to shut down the immune system because you need it to protect yourself, but we want to modulate the immune system to block pathways that are driving inflammation for that particular disease. So after gold, we started using, something called traditional DMARDs, which stands for disease modifying anti-rheumatic drug. And these are kind of broadly work on immune cell activity and proliferation. And these are things like, we call it Plaquenil or methotrexate, kind of the next step up was the biologics, which are fantastic medications. And these are actually antibodies, like lab engineered proteins. And the cool thing about these is they target specific parts of the immune system instead of just broadly stopping immune cell activity. So they work on things like, specific cytokines or blocking things like tumor necrosis factor.
I talked about tumor necrosis factor in episodes 57 and 58. It's a chemical messenger secreted by macrophages, which are the phagocytes derived from the large white blood cells called monocytes. Tumor necrosis factor is a cytokine that induces inflammation, so blocking it is helpful in treating inflammatory conditions.
And then, the other thing we use is something called a targeted therapy. And these are things that enter the cells and block immune pathways inside the cells. And this is like something called a JAK inhibitor. And the cool thing is, like, we use almost all of these medications interchangeably. We can use a lot of these for a lot of different diseases. And I'd say, like, the newest thing on the horizon that's very exciting but is not being used yet, it's in clinical trials, is something where we actually reprogram the immune system. So this is something called CAR T therapy, where we basically like take someone's T cells out of their body and genetically engineer them to then go back into the body and fight inflammation. So that's a very exciting therapy on the horizon. So there's just
Oh,
a evolution and constantly new medications in rheumatology.
that's great. It seems like, especially if you're on social media or if you follow celebrities, Christina Applegate talks about having MS. Jamie Lynn Sigler is another one. She just wrote a book about having MS. Selena Gomez might have lupus.
Yes,
Yeah,
yeah,
yeah. So you
yeah,
hear about it a lot, and I think it's probably really good for awareness that these celebrities are willing to tell their story.
absolutely.
When I was a kid, it was like Richard Pryor, and he was his the end of his life was in a wheelchair and all that, and he also had multiple sclerosis.
Yep.
So, but we hear about that. But then I know that there's different degrees.
Hmm.
So I
Yeah.
wonder if that's like a treatment thing, or if that is just some people get a little luckier.
Yeah.
Things like that.
Yeah, I agree with you. I love when celebrities share that. I'm waiting for Selena Gomez to respond to me. I would love to interview her.
Oh, yeah, that would be great.
But yeah, I mean, yeah, I think that it's very helpful. And I think like Lady Gaga maybe has fibromyalgia, which is not autoimmune, but still just
Oh, okay.
overlaps with autoimmune disease. So I think being open about that is very helpful for people. But yeah, you're absolutely right. I mean, I would say autoimmune disease really exists on a spectrum. And so no two patients with rheumatoid arthritis or lupus behave the same. People have different diseases specific to their body. Some people, for whatever reason, tend to have more mild disease. They just need one medication. And some people have more, fulminant or aggressive disease where unfortunately we have to cycle through meds and see them more frequently and titrate up on things. But the cool thing, as we said, is that we always have new medications coming, and so less is more, and we always try to really target specifically to what's driving disease in patients. And I think we're getting more and more well versed and strong at doing that instead of just general immunosuppression.
Right, right.
Yeah.
So I guess that if I was to ask about the long-term prognosis for autoimmune disease, it would probably depend on what the actual specific disease is, I would imagine. But in
Yeah.
general, is there like, I guess, what could people expect? I guess it just kind of varies, right?
Yeah, but I would say, I mean, this moment in time, we always tell people that they are chronic diseases. There's not a cure for them at this time, and that's important for people to understand. But chronic doesn't mean hopeless. In the past, as you're saying, like people ended up in wheelchairs and on disability and, really, really life-altering, debilitating diseases historically. And that's not the landscape we're in now. I mean, even like that ankylosing spondylitis spine that's fused that we were talking about previously, we're not seeing that nearly as often as we used to because the medications are so good. So I think with early diagnosis, with better therapies, patients can live very long, full, functional lives. And I have a special interest in reproductive health. So just to make a plug for, especially,
Hmm.
women can also have very healthy pregnancies and healthy deliveries, which was not always the case historically.
Yeah, well, that's great news.
Yeah.
Just again, from I grew up in the 70s and 80s. I'm a little
Yeah.
older, and you know, that's what we saw. You saw,
Yeah.
people who, like you said, who the deterioration was stark. And it's really good to hear that that's not the case now, that
Yeah,
it's much easier to live with.
absolutely.
So finally, I want to thank you so much for sharing your expertise with us. Is there anything else you want to share? Is there anything that I didn't think of that you really want to talk about?
Well, firstly, thanks for having me. This was a lot of fun. And I think really the thing I'd like to close with is just that autoimmune disease is very real. It's very complex, as we know now, as we just talked about it. And it's often invisible. I think in a lot of support groups and whatnot, they call it, and they call these things like an invisible illness. So I think it's important for listeners, whether you are going to, practice medicine or physical therapy or whatever you're going into, or if you're a patient listening, it's just important to know that a lot of the patients who end up in this seeing rheumatologists have felt dismissed or misunderstood, or sometimes told that this is something they caused. And I think it's very important to know that that's not the case. And getting evidence-based treatment is not a failure. It's really how we protect someone.
Insurance isn't one size fits all, and shopping for it shouldn't feel like squeezing into something that just doesn't fit. That's why drivers have enjoyed Progressive's Name Your Price tool for years. With the Name Your Price tool, you tell them what you want to pay, and they show you options that fit your budget. Enough hunting for discounts, trying to calculate rates, and tinkering with coverages. Maybe you're picking out your very first policy, or maybe you're just looking for something that works better for you and your family. Either way, they make it simple to see your options. No guesswork, no surprises. Ready to see how easy and fun shopping for car insurance can be? Visit Progressive.com and give the Name Your Price tool a try. Take the stress out of shopping and find coverage that fits your life on your terms. Progressive Casualty Insurance Company and Affiliates. Price and coverage match limited by state law.
So, Dr. Alexis, I mentioned that I had been following you on Instagram. Can you please share with the listeners where they can find you on social media and benefit from all of the things that you have to share?
Yes, I'm on Instagram and TikTok and Facebook, all under Dr. Alexis _MD.
Excellent. I will post those to the show notes so that people can click on them and find you. I will tell you, as the listeners, that I found Dr. Alexis on Instagram. I started following, listening to all the really, really good things that are shared. I highly recommend a follow, and you can learn a ton, which is how I reached out and decided that I would love to have Dr. Alexis on.
Thanks so much, Steve.
So thank you once again. I really appreciate it.
Yeah, thank you so much.
I cannot thank Dr. Alexis enough for sharing all of this knowledge. Boy, did treatments change for the better since I was a student. I highly recommend following Dr. Alexis on Instagram or TikTok. Both are at Dr. Alexis _MD. I will put a link in the show notes so that you can find her easily. Thank you all for listening. We are knee-deep in the application of anatomy and physiology now. This is where your level of understanding will soar past memorization. I hope this podcast is helping you get your B or better in A&P. Good luck, be well, and I'll talk to you next time. Anatomy and Physiology Bit by Bit is a production of Minus 55 Media and is hosted by the Believe Network. Please take the time to rate my show and leave a review. You can also check out the content I post on Instagram and YouTube as @StudentHelp4AP. That's the number 4 AP. Special thanks to my family, Bucks County Community College, and McGraw-Hill Education, where your instructor can find Anatomy and Physiology Digital Suite, my low-cost tutor video-based digital learning solution for anatomy and physiology currently being used at several colleges and universities. If your instructor isn't using Digital Suite, let them know about it. The link is in the show notes.
You're listening to this podcast, so I know you've got a curious mind. Here's a helpful fact you might not know yet. Drivers who switch and save with Progressive save over $900 on average. They make it super simple. Pop over to Progressive.com, answer some questions, and you'll get a quick quote with coverage options tailored to your choices. Plus, you'll see which discounts you may qualify for, like the online quote discount or savings for paying in full. In fact, 99% of Progressive Auto customers earn at least one discount. See if you could save when you switch to Progressive. You'll feel good about making a savvy choice. Visit Progressive.com and see if you can enjoy a little extra cash back. Progressive Casualty Insurance Company and Affiliates. National average 12-month savings of $946 by new customers surveyed who saved with Progressive between June 2024 and May 2025. Potential savings will vary.
If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.